ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ. ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಘದ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಚಿರಾಯುವಾಗಿರಲಿ. ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಓವರ್ ಟು ಡಾಕ್ಟರ್ ಕರವೀರ ಪ್ರಭು.
ಇವತ್ತಿನ ವೆಬಿನಾರ್ ಸೆಮಿನಾರ್ದ ಕೇಂದ್ರ ಬಿಂದು ಹಿರಿಯರು ಹಾಗೂ ಚರ್ಮರೋಗ ತಜ್ಞರು ಉಪನ್ಯಾಸಕರಾದ ಡಾಕ್ಟರ್ ಕೆಲೋಜಿ ಹನುಮಂತಯ್ಯ ಅವರನ್ನು ವೈಯಕ್ತಿಕವಾಗಿ ಮತ್ತು ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಪರವಾಗಿ ಹೃತ್ಪೂರ್ವಕವಾಗಿ ಸ್ವಾಗತಿಸುತ್ತೇನೆ. ಅವರು ಇಂದು ಕಾಮನ್ ಸ್ಕಿನ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇನ್ ಜನರಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಎನ್ನುವ ವಿಷಯದ ಬಗ್ಗೆ ಉಪನ್ಯಾಸವನ್ನು ನೀಡಲಿದ್ದಾರೆ. ಇವತ್ತಿನ ಸೆಮಿನಾರ್ಗೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ರಾಜ್ಯಾಧ್ಯಕ್ಷರಾದಂತಹ ಆತ್ಮೀಯರಾದ ಡಾಕ್ಟರ್ ವೀರಭದ್ರಯ್ಯ ಅವರಿಗೆ ಹಾಗೂ ಕಾರ್ಯದರ್ಶಿಗಳಾದಂತಹ ಡಾಕ್ಟರ್ ಸೂರ್ಯರಾಜು ಅವರಿಗೆ ಮತ್ತು ಉಳಿದಂತಹ ಎಲ್ಲ ಶ್ರೋತೃಗಳಿಗೆ, ಮಾಜಿ ಅಧ್ಯಕ್ಷರಿಗೆ, ಚುನಾಯಿತ ಅಧ್ಯಕ್ಷರಿಗೆ ಹೃತ್ಪೂರ್ವಕವಾಗಿ ಸ್ವಾಗತವನ್ನು ಕೋರಿ ಡಾಕ್ಟರ್ ಕೆಲೋಜಿ ಹನುಮಂತಯ್ಯ ಅವರು ತಮ್ಮ ಉಪನ್ಯಾಸವನ್ನು ಪ್ರಾರಂಭ ಮಾಡಲು ಕೇಳಿಕೊಳ್ಳುತ್ತೇನೆ.
ಸರ್, ಇಂಟ್ರೊಡಕ್ಷನ್.
ಸಾರಿ. ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಅವರು ಡಾಕ್ಟರ್ ಕೆಲೋಜಿ ಹನುಮಂತಯ್ಯ ಅವರ ಬಗ್ಗೆ ಪರಿಚಯವನ್ನು ಮಾಡಿಕೊಡುತ್ತಾರೆ.
ಅಧ್ಯಕ್ಷರು ಯಾವಾಗ ಮಾತಾಡ್ತಾರೆ? ಕೊನೆಗೆ ಮಾತಾಡ್ತಾರಾ ಅಥವಾ ಫಸ್ಟ್ಗೆ ಪ್ರೆಸಿಡೆನ್ಷಿಯಲ್ ರಿಮಾರ್ಕ್ಸ್ ಇರುತ್ತಾ, ಹೇಗೆ?
ಸರ್, ಉಪನ್ಯಾಸ ಮುಗಿದ ಮೇಲೆ ಮಾತಾಡ್ತಾರೆ.
Dr. Keloji Hanmantaya. He completed his MBBS graduate from Mahadevappa Rampure Medical College, Gulbarga. And he is a meritorious student and he was awarded cash prize for merit in the pre-final and final MBBS. Then he joined diploma in venerology and dermatology from in Karnataka Institute of Medical Sciences, Hubli. And he also completed his MD dermatology in JNMC Belgaum. He joined as a medical officer in PHC Andiganur, Haveri district. Then also he was awarded for cash incentive by the government of Karnataka for achieving family planning target. And he was a medical officer in the National Leprosy Control Committee from 84 to 90. And he was deputed as to do MD dermatology in JNMC Medical College, Belgaum. And till today, he is a teaching faculty in KMC Hubli and Sri Devaraj Aras Medical College, Kolar. And his contribution to the dermatology is his publication about 50 articles in medical journals, contributed 2 chapters in the Springer publication, Men's Health. And he has attended many state, national and international conferences, and he is a PG examiner and trained at Central Leprosy Training and Research Institute, Chengalpattu, Tamil Nadu, for leprosy, and Government Hospital, Tambaram, for HIV and AIDS. So I welcome Dr. K. Hanmantaya to give the speech on the topic common skin problems. I welcome you, sir. Dr. Hanmantaya, sir.
Thank you, sir. Thank you.
My sir, presidential remark will be before lecture, no, sir. Just
Okay.
Yes, sir.
Sir, I welcome Dr. Veerbhadra, sir, respected President IMA KSB, to give a talk and welcome the audiences. Hello.
ಹಲೋ
Sir,
Yes, sir. Audible, sir.
continue, sir.
ನಮಸ್ಕಾರ.
ನಮಸ್ಕಾರ ಸರ್.
ಇದು ಸರ್ದು ಮೂರನೇ ಇದು ನಾವು ಕೇಳ್ತಾ ಇರೋದು ಪಾಠ.
ಸರ್.
ತುಂಬಾ ಚೆನ್ನಾಗಿ ಮಾಡ್ತಾರೆ. ತುಂಬಾ ಚೆನ್ನಾಗಿರೋ ಇದನ್ನೆಲ್ಲ ತೋರಿಸ್ತಾರೆ. ಜನರಲ್ ಪ್ರಾಕ್ಟೀಷನರ್ಸ್ಗೆ ತುಂಬಾ ಅನುಕೂಲ ಆಗುತ್ತೆ. ಅದರಿಂದ ಈ ಒಂದು CME ಚೆನ್ನಾಗಿ ಮೂಡಿ ಬರಲಿ. ಸರ್, ಇನ್ನು ಹೊಸ ಹೊಸ ಕಾಯಿಲೆಗಳ ಬಗ್ಗೆ ಏನಾದ್ರು ಇದ್ರೆ ತಿಳುವಳಿಕೆ ಮಾಡ್ಕೊಳ್ಳಿ ನಮ್ಮ ಜನರಲ್ ಪ್ರಾಕ್ಟೀಷನರ್ಸ್ಗೆ ಅಂತ ಕೋರ್ತಾ ಓವರ್ ಟು ಸರ್.
Sir, thank you, sir. Thank you, sir. Let us respect our great God, Dhanvantari. Om Namami Dhanvantari Adi Devam Surasura Vandita Pada Padmam Loke Jararudba Muttu Nashakam Datara Isham Vividaushadhanam Kshirodana Mantarat. Son, my inspiration goes to my teacher, Dr. P.S. Shankar, who taught ABCD of my medicine, now 86 years, present working in Gulbarga. Dr. Srinivasan sir, senior most surgeon, spot decision, wonderful clinician. Dr. Ramegowda sir, senior physician, and the way he takes every patient as a new patient and first patient. So with every patient, the way he is treating, these three teachers are all the time my inspirators. Friends, today I asked my private practitioner friends in Kolar what I should speak to IMA. Almost 10 of them, they told you stress more on bacterial infection, viral infection and fungal infections instead of talking very rare diseases. So within last 10 days, whatever patients I got in my OPD, same patients photographed and now I am presenting to you. Basically, dermatology is a visual discipline. Repeatedly you see, you train your eyes. Whatever you see in literature, try to compare it. Then only we will come to know that dermatology is the simplest of simple medical branch. The eyes do not see what your mind does not know. Friends, our skin is an totally 100% external covering. All the 24 hours of 365 days, it is bombarded by these toxins. The scorching sunlight, of course, today, the almost severe cold, the smoke, the fume, the poisonous gases, the bacteria, the chemicals. We are all doctors. So in addition to common man, we are going to attend our hospital. There are also some more chemicals. All these chemicals, bacteria, scorching sunlight, they will be acting on our body. But today we are concentrating more on pathogens. The commonest organisms which infect our skin are the bacteria, viruses, and the fungi. The infection may be through airborne vectors, fomites, or sexually, or through internal organs. Friends, this particular chart is common for each and every disease. We encounter a pathogenic organism. This organism will enter our body. It will go to a susceptible zone. Let us take meningococci. Unless it reaches meninges, there will be no infection. Pneumococci, unless it reaches alveoli, no infection. Gonococci, urethra. Similarly, staphylococci and streptococci, when they reach the skin, they cause skin infection. Then once they reach susceptible organ, they multiply into enormous number. When they multiply into enormous number, then they declare war with the host. When they declare war with the host, if the host wins, bacteria is killed. If the bacteria wins, a person will get either a disease or he may die. But if the organism is friendly, let us take Escherichia coli. So whatever left in fecal matter, it will take and it will give little B complex to our body. So this what is called as a commensal. The most evolved organisms is this particular commensals. The least evolved, the bacteria which get killed or which will kill the host. Friends, the bacterial infection may be simple, primary, 100% skin is healthy, then the organisms have attacked. Or when already there is a disease, for example, because of the scabies, because of the superficial burns, or because of the trauma, then the organism enters and produces the disease. We call it the secondary pyoderma. Just simple impetigo, ecthyma, folliculitis, cellulitis, pyoonychia, staphylococcus, scarlet skin syndrome. We'll see one by one. See, here is a child. Earlier I told dermatology is a visual specialty. Today I am going to show you only the photographs which I have taken in last 10 days. So this particular child, see the lip, the chin. So here in between there is a yellow honeycomb colored crusts are there. This is the beginning of infection. Here another child, the entire, both the eyebrows, both forehead and little scalp region full of crusted lesions. Here a child is having a pyoderma lesion for which mother has applied turmeric. Here there are lesions, crusted lesions, 100% clear cut crusted lesions. So they spread from one part of the body to another part of the body. Here a crystal clear pus is there. There is a one particular upper limit. So this upper limit we call the hypopion sign. And here this lady has applied the Vicks on these particular lesions. These are all called impetigo. What is the meaning of impetigo? Attack. Attack by what? Pyococci. Pyococci means staphylococci and streptococci. And they have produced these type of lesions. We call it the impetigo contagiosa. See here, impetigo. These are all pus-filled lesions. What is the specialty? Carefully see the skin. This is the skin, only intraepidermal. It is a purely intraepidermal. Hence, the basement membrane is intact. All these lesions heal 100% efficiently. Absolutely no scar formation. Here, see, this has gone little deeper. Still it has gone deeper. What is the reason? Number one, basic negligence of the patient or negligence of the relatives. The trauma, continuous trauma, underlying diabetes mellitus. So what has happened? The patient develops surrounding the lesion erythema, edema, pain increases. Here it is present on the knee joint. Patient is having a difficulty to walk. This is a 8-month child. The child initially has developed impetigo. Mother totally neglected. Then this particular scar. So this scar is nothing but a dead skin, a necrotic skin. It feels leathery. It is called eschar. Eschar basically a protective in nature, but comes in the healing process. So these are, if we do not treat pyoderma well in advance, then they go into ecthyma. Ecthyma is a extended infection. Here, folliculitis. Folliculitis means what? Hair follicle infection. When a single hair follicle is infected, inflamed, we call it a folliculitis. So same folliculitis, when we see the our farmers, they walk in the land, and almost all the time their particular skin come in contact with the shrubs, herbs, and thorns, leaves, and entire leg will get impetigo. This type of impetigo of our Indian farmers we call as a Bocard's impetigo folliculitis. Here, this particular patient has gone to a barber shop, and after taking a getting shave, he has applied some chemical which he do not know, and he has developed almost entire area pustules. Here is a pustules. So folliculitis means inflammation of the hair follicle, and this carefully if you see, this is the hair follicle, but entire surrounding area is so much inflamed. So much inflamed. Here, carefully you see, this is the dot where pus is present, but almost 1 centimeter to 2 centimeter, the area is edematous. Lot of pain is present. When hair follicle infection plus surrounding tissue inflammation, then we call the furuncle. Furuncle is again neglected, just like a neglected case of ecthyma. If hair follicle is not treated, then it will go for furuncle. Suppose here, carefully you see this furuncle. Here is a furuncle, but edema of the upper eyelid, lower eyelid. So periocular edema. Actually 100% eye is normal. Because of this particular furuncle, so much reactive edema. This is called reactive edema. This child, so this particular sweat gland inflammation, and now they have formed totally abscess. So this we call the periporitis. This particular vestibule of the nose, here hair follicle infection, and entire nose is so much inflamed. He will not allow us to touch. Friend, he is our own doctor friend. 8 days back, he had a joint pain. He started taking on his own the Brufen paracetamol tablets. Then, after 6th day, he started developing little uneasiness, weakness, difficulty to get up from the bed. Then, after 8 days, he was brought to the hospital. When I saw him, so there was a total abscess formation on the upper lip. But more than that, the conjunctiva was dead pale. I was shocked. I asked the doctor, what is the reason? Then he told, I have taken Brufen paracetamol for 10 days. Immediately I took him to our physician friends, and they told it is almost bone marrow suppression has taken place. So bone marrow suppression for the drugs, and then he has developed abscess. It is an emergency case. This particular patient, he had already sebaceous cyst on the nape of the neck, and then over that he has developed pustule. When multiple furuncles come together, single hair follicle, folliculitis, multiple folliculitis, furuncle, the surrounding area. When multiple furuncles come together, we call it a carbuncle. So here is a carbuncle. 25 years back, any patient coming with the carbuncle, the only diagnosis underlying diabetes mellitus. But today, there are so many other causes are there. For example, he may be suffering from immunosuppression. It may be primary or acquired, or he may be taking steroids. He may be taking cancer chemotherapy. Today, causes for immunosuppressions are more. This is called psychosis Barbe. So beard region, it shows hair follicle infection. So this is the acute infection, and this is a chronic infection. Friends, this is called superficial spreading inflammation of the cheek and ear lobule. It is a superficial spreading cellulitis. Similarly, here, this particular gentleman, superficial spreading cellulitis starting from the thighs goes towards the knee joint and upper 1/3 of the leg. So this is we call the erysipelas. When there is an inflammation of the subcutaneous tissue, then we call the cellulitis. The only difference between the cellulitis and erysipelas is more of a superficial spreading lesion. The cellulitis is of a subcutaneous tissue inflammation. Friends, there are 3 more infections of the skin: erythrasma, pittate keratolysis, and trichomycosis axillaris. Here, this particular gentleman, carefully see the entire axilla. The entire axilla is like a dark brown and little reddish lesions. Mild scaling is present. This is called erythrasma caused by Corynebacterium. Here, the axillary hairs, carefully see, especially the labor workers, men's workers, because of the scarcity of the water, they take bath whenever they get the water, maybe once in a month or once in a 10 days. So at that time, the sweat and the bacterial colony make colonies over the axillary hairs. See, these are all just like a cementing substance put around the hair shafts. This is called trichomycosis axillaris. Here, unfortunately, the word mycosis is there, but here they are all diphtheroids. Carefully see the plantar aspect of the forefoot. There is a small depressions are there. These small depressions are nothing but the bacteria have eaten away the stratum corneum. This is called pittate keratolysis. Those people who are continuously working in water, especially bathroom, dhobis, or even maid servants. Here in between the toes, the entire skin is peeled. So the entire skin is peeled. So this is a classical erosive intertrigo. This is a child. This child had a scabies. Because of repeated scratching, he has developed a trauma. Trauma to which the oozing of serum takes place. Streptococci are attracted and they produce inflammation. We see secondary infection. Basically, it is a scabies with secondary infection. The skin was originally damaged because of the scabies. So that's why we call the secondary pyoderma. Here it is a traumatic lesion. Traumatic lesion because of the oozing of the serum, so bacteria invaded. So damage of the skin was there. So that's why we call it the secondary pyoderma. Friends, this is a nail plate, lateral nail folds and proximal nail folds. In between the proximal nail folds and nail plate, so there is a little infection. 99% of the time, it is a mixed infection, both bacteria and fungus, candida. So we call it the paronychia. When we are planning to treat, we have to treat both the condition. Both the condition means fungus and bacteria. Friends, we have to manage these pyodermas. Identify, assess, and treat predisposing factors. Poor hygiene, malnutrition, recurrent trauma, diabetes mellitus, pre-existing skin lesions, everything we have to take into history. Then particularly treat predisposing factors like diabetes mellitus. Wherever necessary, culture and antibiotic sensitivity is good. Topical therapy, number 1, regular bath, regular Condis compressions, Burroughs solutions, topical antiseptics, or topical antibiotics. Friends, there are already very good antibiotics are available in the market. The best among all of them, the good old soframycin. Even today, soframycin is a wonderful drug, topical antibiotic. Mupirocin, topical mupirocin, topical fusidic acid. Now, latest edition is vaginoxacin. So these are ready-made creams. So as far as bacterial infection is concerned, only the topical creams, they do much wonder. So carefully you should see that these should not contain steroids. So simple soframycin, mupirocin, fusidic acid, ozenoxacin, any one or nadifloxacin can be given. If necessary, ampicillin, amoxicillin, augmentin, or ciprofloxacin, levofloxacin, ceftriaxone, ceftriaxone, erythromycin, tetracycline, doxycycline, any of the systemic antibiotics can be given. So once again, the topical, the creams are soframycin, nadifloxacin, mupirocin, fusidic acid, and ozenoxacin. Friends, when we come to the viral infection, commonest viral infection is herpes simplex, varicella zoster, verruca vulgaris, and molluscum contagiosum. Herpes simplex. Usually, parents will come and tell, my child will be getting regularly common sore. Whenever common cold is there, then we see around the nostrils, around the upper lip or lower lip, angle of the mouth, we see small blisters or water-filled lesions. We usually call it the cold sore. Or other relatives will come, whenever he gets a fever, he will get the vesicles in and around the nostrils. Classical fever blisters. The synonyms for herpes simplex, cold sore or fever blisters. When we see herpes simplex virus, we broadly group into type 1 and type 2. Type 1 usually causes herpes simplex or herpes labialis. Type 2 usually causes herpes genitalis. But because today the sex practice is almost changed, so we see herpes type 2 herpes virus on the lips and vice versa. The investigation simple. Junk smear or HSV1 and 2 antibodies. Usually we go for IgG and IgM. If IgM is present, it is an acute infection. If IgG is present, it is a chronic infection. Friends, carefully see the angle of the mouth. There is a grouped vesicular eruptions. Grouped vesicular eruptions over an edematous background. Dew drops on rose petals. See, here one more child. So here there are vesicular eruptions in the angle of the mouth. Here entire upper lip, there is a one group, another group. Grouped vesicular eruption over an erythematous and edematous background. Here atypical presentation. The grouped vesicular eruptions over the elbow. It is definitely atypical. Whenever atypical is there, think of HIV background. Of course, he was HIV positive. Yes, most of you can diagnose. He is a treating physician because he was of neglect in examining the patient. So the herpes of fingertip, herpetic whitlow. This patient came to me as a non-healing ulcer. First time I started one topical good antibiotic and oral antibiotic. At the end of 5 days, no improvement. I started oral 2 antibiotics and topical, I changed the antibiotic. At the end of another 5 days, no change, but the patient's condition became worsened. He had a difficulty in taking breath. Immediately when I took him to radiology department, fluoroscopy, they found out bilateral pleural effusion. See, this is a non-healing ulcer. Patient is showing worsening of the condition. Then I started rethinking. I got immediately that particular pleural fluid analyzed. It was Mycobacterium tuberculosis. And then carefully I saw here this particular clinching point. This is called island of normal skin. Usually, I had not noticed it earlier. But when patient developed pleural effusion and secondary, it was HIV positive. Then I immediately got for HSV, herpes simplex virus, IgM and IgG, both were positive. A non-healing ulcer. If we see central island-like skin, first and foremost think of herpes and background HIV positivity. Here, patient is having a very extremely thick crust. He is not able to breathe properly. Then, when HIV was done, HIV was positive. Here, repeated soaking of the crust continuously 8 to 10 times a day. And then, slowly, whenever we started soaking, the superficial layers becoming loose and started getting separated from the main crust. So, over the total 3 days, we removed the crust and we treated for herpes. Of course, HIV treatment. See here, a young, energetic, sexually active man came with the grouped pustular lesions over the shaft of the penis. Here, the ulcerated lesions. Here, the ulcerated lesions. And the lady inside the labia minora, superficial shallow ulcers. HIV was done in all the 4 patients. HIV was positive. We have to treat both herpes and as well as HIV. Second virus infection is chicken pox and herpes zoster. Both are caused by only one virus, varicella zoster virus. When it enters our body, it educates our immune system. Immune system understand that I have done a mistake of allowing this virus to enter my body. It has spread all over my body and it has produced vasculitis and chickenpox lesions have developed. By chance, next time it starts appearing or invading our body, immediately it prevents its spread. So next time or subsequent time when varicella zoster virus enters our body, the infection is limited. When it is disseminated, we call it the chickenpox. When it is limited, we call it the herpes zoster. It spreads by droplet infection. The herpes zoster is called by many names: dermodynia, mucodynia, sclerodynia. Herpes zoster sine herpes zoster. I want to take the example of our late Chief Minister Devaraj Arsar. Devaraj Arsar developed a severe pain in the angle of the mouth, right side. Immediately he was taken to one of the major medical college hospital. There, a dental surgeon saw and he told it is a root infection of the third molar. It was extracted. Next day, Chief Minister sir came with some more pain. Then the dental surgeon told, no, we should remove second molar. Then third day, pain increased. Then again sir came. At that time, dental surgeon told the infection has spread to first molar also. This time, Chief Minister became angry and he told, no, I want treatment from the then great physician, Dr. Rudrappa sir, who was the medical director of our Karnataka. So he told, this particular condition is simple herpes zoster. So here he has developed herpes zoster sine herpes zoster. It means herpes zoster lesions are there, but the vesicles are not there. The absence of vesicles we call the herpes zoster sine herpes zoster. Then why the varicella zoster when chickenpox was there? Now it comes as a herpes zoster because varicella zoster virus lies dormant in sensory root ganglia. So predisposing factors for reactivation of this varicella zoster virus is old age, intercurrent infection, lymphoreticular malignancy, or HIV, or without any apparent cause. What are the complications of herpes zoster? Post-herpetic neuralgia, Hutchinson sign, whenever tip of the nose is involved, automatically concerned, if it is right side, right eye get involved. So presence of a single lesion on the tip of the nose, it should tell us that we should be very careful about the eyes. Secondary bacterial infection, it may become multidermatomal, bilateral, disseminated chickenpox-like lesions may complicate segmental herpes zoster. So that time we should expect either underlying internal malignancy or HIV infection. Motor paralysis also develop. See here, carefully you see a umbilicated lesion over an erythematous background. So what we call as a dewdrop on rose petal. These are all chickenpox lesions. So herpes zoster, usually it follows one dermatome. If it has present more than one dermatome, think of HIV background. Here, almost so many vesicular, the hemorrhagic vesicles. So presence of hemorrhagic vesicles indicate that herpes zoster, probably HIV background. Here, classical herpes zoster, grouped vesicular lesion along one particular dermatome. So grouped vesicular infection, grouped vesicular lesions in one continuous dermatome. Here, herpes zoster ophthalmicus. Here, carefully you see this lesion is present on the tip of the nose. Automatically, that particular eye, patient has developed iridocyclitis. So classical, this is called Hutchinson rule. So Hutchinson rule says that if the tip of the nose is having one vesicle, think of immediately involvement of the eye. Treatment for herpes simplex or herpes genitalis, you give acyclovir little smaller dose. If it is a chickenpox or herpes zoster, you have to give little higher dose, starting from 800 milligram 5 times a day. But friends, honestly, I tell you, so almost I am 72. Till today, I am extremely happy with the acyclovir 400 milligram 3 times a day. Other drugs are famciclovir, valacyclovir, along with analgesics, antibiotics, soothing agents. You should never prescribe topical acyclovir. Any drug which you use topically and at the same time you use systematically, you are encouraging sensitization. So that's why topical, you can give calamine lotion or fusidic acid. Verruca vulgaris. So what is Verruca vulgaris? Viral warts. So viral warts, they are depending upon serological variations. So many variations are there. Among them, number 16, number 18, number 31, number 33. These serological variations, they go for squamous cell carcinoma. So the why we need all these variations is to see whether in future patient is going to develop squamous cell carcinoma. Especially number E6 and E7 genes, they produce telomere shortening. Once telomere shortening takes place, the ends of the chromosome become sticky and fuse with the other chromosomes and become immortal. It means they go towards the squamous cell carcinoma. See, viral what? There are two viral what. This is number 1 and this is number 2, lower eyelid. Number 1, number 2. This is one more on the upper eyelid. Multiple viral warts are there. But carefully see, here the child has scratched. Along the scratch line, the warts have developed. This is called isomorphic phenomena or Koebner's phenomena. This is the isomorphic phenomena. Along the troma, the lesions have developed. So many warts, so many warts, so many warts. See, so many warts. When more than 10 are there, think of immunosuppression, think of HIV positivity. Wart on the nail plate. It is a great toe underneath the nail plate. Difficult to treat. Difficult to treat. Plantar warts. Difficult to treat. Genital warts, when the warts are present on the shaft of the penis or vagina. See, viral warts. The treatment, extremely easy. Phodophyllum. So the treatment is phodophyllin resin or phodophylotoxin. So today, phodophylotoxin is extremely good. You can take and apply on the lesions. So every alternate day apply for 4 to 5 days. So automatically the lesions melt like a butter in the sun rays. So phodophylo resin is little stronger. Phodophylotoxin is much milder, easy to apply in the our own outpatient. In a medical college, cryotherapy, lasers, electrosurgery, imicomode, all are given. But in a practice, phodophyllum resin or phodophylotoxin is a wonderful drug. Then, friends, here, such a innumerable viral warts are there. Here, the treatment purposely I did not write. The reason I requested my best friend to treat this condition. So my best friend is a homeopathy practitioner. He gives Tuja. So Tuja is given in the form of 400, 600, 800 concentration. So higher the concentration, it is the stronger the drug. So as far as homeopathy is concerned, Tuja is wonderful. But when we are treating this viral warts, we should request our homeopathy practitioner friends to treat, because absolutely it will not leave any. I have totally maintained 3,500 cases registered. All 3,500 cases totally 100% recovered. Almost continuously followed up for more than 10 years. No recurrence of the lesions. Molluscum contagiosum. When I joined my diploma in 1978, my professor called it is a gift from your girlfriend. But when I joined my MD, that time my professor told it is a deadly friend. So this is a molluscum. So it looks like a pearl, basically pearl. So that's why my first teacher called it is a lovely pearl, gift from a girlfriend. But by the time I did my MD in 1990, HIV was almost rampant. The molluscum contagiosum does not come all alone. It comes along with the HIV infection. So here, if the lesions are elsewhere other than genitalia, first and foremost, ask for HIV test. If HIV test is positive, then request the patient to take treatment from ART centers only. Repeatedly, not once, 10 times you tell the patients to take from ART centers. The reason is HIV drugs are not 1 day, 1 month, or 6 months treatment. It is for many years. So continuous patient has to take drugs. So at that time, if he goes to ART centers, he will be properly registered and follow-up will be better, and they will take continuous medication. So once ART is given, many times these molluscum contagiosum may regress. Otherwise, with the one simple 21 number or 20 number needle, make a small nick in the periphery and squeeze it out. Entire thing will come out. What we call as scooping. Here, multiple molluscum contagiosum, multiple virus over the vulva. So all these 4 patients HIV positive. Fungi, yes, there are yeast, there are molds, and dimorphic fungi are there. Classical yeast, Cryptococcus neoformans, yeast like Candida albicans, and this filamentous fungi, what we call the dermatophytes or tinea. Then there is one more variety, dimorphic. When it is seen in the body, temperature is more. It looks like a yeast like. But when it is grown in the cooler atmosphere, it goes like a filamentous fungi. The double behavior of the fungus we call the dimorphic. All systemic fungi, aspergillosis is classical of dimorphic fungi. They are superficial mycosis and deep mycosis like subcutaneous and systemic. I will cover dermatophytes, Tinea versicolor, Tinea nigra, Pydra and Candidiasis. See, this particular child, carefully you see, there is a loss of hairs, but you are seeing black dots. So this is called black dot tinea capitis. Here, there are patches are there, multiple patches are there, but little scaling and few hairs are there. So this is called gray patch. So this is a black dot and gray patch. Black dot is called endothrix and gray patch ectothrix. And there is a lot of inflammation. So this lot of inflammation we call the chirion. The black dot and gray patch non-inflammatory tinea capitis. This is a inflammatory tinea capitis. See here the entire shoulder, the abdomen. See entire heavy lesion. Here, see the entire sibling, all brothers and sisters, they are having such a extensive fungal infections. Such a extensive fungal infections are there. So it means these particular relatives, they take bath together, they use same towel to mop their body. So the infection present in one person will spread to another person. So the classical of tinea corporis. This is the tinea cruris. This is the tinea cruris. Tinea cruris. The entire gluteal region. The entire gluteal region is having so much inflammation and scaling. Classical of tinea cruris. The fungal infection of the nails. Tinea unguum. In between the toes, there is a scaling is there. There is a cream. Almost this you looks like a curd. It looks like a cream. A curdy, creamy scaling, moist scaling. Typical of Candidal intertrigo. This is what we call the tinea versicolor. Here this is more of a hypopigmented lesion. Here hyperpigmented lesion. So hyperpigmented lesion, hypopigmented lesion. Classical of tinea versicolor, most superficial fungus. This almost black colored, we call the tinea nigra, and black deposits over the shaft of the hair called black pydra. He is in one of the nationalized bank senior manager. He came and told he is having a difficulty to retract the prepuce. So he tried to do it. Then he saw a cracks, severe crack and oozing of the blood. After 2 treatment, so we could take out the prepuce. Then we saw underneath the prepuce and over the glass penis, creamy, curdy scaling is present. We convinced him and got blood sugar. It was almost 400 milligram percentage. He was not aware that he is having diabetes. The first presentation of the diabetic patient is candidal belanoposthitis. Candidal vulvovaginitis. Candidal vulvovaginitis. Oral thrush. Of course, here HIV was positive. Candida of the tongue. Angular cheilitis with glossitis. See, all these fungal infections. One is clinical examination. What is the clinical clinching point? Clinching point is see the border. 100% well-defined border. If there is a 100% well-defined border, with active spreading inflammatory lesions on the border. Only the diagnosis is fungus infection. Then take the scrapings, examine with the help of potassium hydroxide. You will see hyphae. If necessary, culture and do antifungal. And at the same time, if necessary, go for any the comorbidities like diabetes mellitus or immunosuppression. Treatment, yes, you advise them hygiene. Every day they should take bath, and every day they should wear dry cotton clothes which are little loose to fit. Then do not share the towels with the brothers and sisters, especially even garments, combs, antifungal creams, powders, tablets should be taken for minimum of 4 to 6 weeks. When we come to the bacteria or virus, we tell 5 to 7 days. But here we tell 5 to 7 weeks. The good old clotrimazole, that is a candid cream. Even today it is wonderful. Especially it is extremely good for candidal vulvovaginitis, candidal melanopasthitis. The ketoconazole cream, lalliconazole cream, oxyconazole cream, sertaconazole cream, emrolfin. So many drugs have entered the market today. Market is full of antifungals. Only what you should do, you should never use a steroid combining these drugs. Only you use plain antifungals like Candid, KZ cream, Lalifin, oxyconazole, or sertaconazole, or fungicross. The powders, Candid powder, keto powder, Epsor, Mycoderm, even the soaps have come, keto soap has come. The tablets, friends, the oldest still good tablet is Grisofulvin. But today, throughout India, fluconazole is extremely popular. So fluconazole can be given 150 milligram alternate day for 6 to 8 tablets or continuously for 14 days. Itraconazole, most safest drug. We can give 100 milligram 2 times a day for 2 to 6 weeks. Terbinafine 250 milligram daily for 4 to 6 weeks. The difference between a bacterial infection and fungal infection is you give in weeks, there you give in days. So if you combine steroid induced complications are much more than treating single condition. When we do not know, at that time we can use one of the cream, for example KZ cream or Candid cream with fusidic acid. Should wait for 10 days. If it doesn't subside, refer to one of your dermatologist friend. So friends, any questions, I will be happy to answer today if I know. Thank you. Thank you very much.
Thank you very much, sir, for your wonderful presentation. And the picture and photographs what you have taken is really very knowledgeable. And the skin diseases can be identified by seeing the pictures what you have shown. And we thank for your wonderful presentation, sir. Any questions from the audience?
Sir, I have one question, sir.
Please,
Very
please ask.
good presentation, sir. The fungal infections recurrences are very common now, sir, because sometimes they treat with local ointments and with oral medications, and after that also, like the chances of recurrence is very high. What is your opinion, sir? What precautions people should take to prevent recurrence?
Your observation is 100% clinical, practical. Number one, we ask the patient to apply the ointments, but we do not properly guide them. When they take bath, for example, crural region, when they take bath, immediately without wasting single second, they wear the undergarments or pant shirts. See, already whatever they have taken bath, little water will be there. Those 1 or 2 drops will get absorbed into the undergarments. Undergarments will become wet, and this wet undergarment will come all the time in contact with the skin, and that particular local area of the skin will become moist and weak, and it will make the fungus to enter once again and again. This is number one. Second, most of the people nowadays they go on two-wheelers or four-wheelers where the resin sheet will be there. On the resin sheet continuously sitting for half an hour or 1 hour. So the whatever sweat develops in the crural and gluteal region, that will be absorbed by undergarments, and once again it will become wet. So that's why what we have to tell, when you are taking antifungal drugs, number one, you give little extra 5 minutes after taking bath. So slowly you dry that particular area with not only one towel, you use 2 towels, number one. Number two, if you are driving vehicles, you change the undergarment twice a day. Number three, so compulsorily take the antifungal drugs for minimum of 2 to 4 weeks, whatever is prescribed. So if they forget any of these principles, then they get a recurrence of the lesions. If there is a recurrence of the lesions, ask for either blood sugar or any comorbid lesions, sir.
Thank you, sir. Because I very often come across urology, means nephrology cases with immunosuppression with uncontrolled diabetes.
Yes,
Their
sir.
fungal infection, most common complaint, and they keep telling, they get a recurrence. That's why I asked this.
If we take the Hutchison textbook of medicine, he clearly mentions, advise the patient to take 150 milligram fluconazole for continuous 14 days, 2 weeks.
Oh.
Yes, sir. It is a really wonderful drug, and especially soon after bath, that entire body should be kept made dry, and you should wear simple, loosely fitting cotton clothes.
Thank you, sir.
Sir, good evening, sir.
Yes, sir.
Sir, any modalities of treating this hyperhidrosis condition, sir? The palm and so.
Hyperhidrosis is a really big problem, sir. It is a combination of 3 specialties. One is extremely good psychiatric analysis. Most of the time, it is because of the anxiety neurosis, there is a hyperhidrosis. Number one. Second, endocrinology, especially thyroid problem. Nowadays, thyroid problems are increasing. So these are the 2 common conditions. So we should take the help of our psychiatry friend and endocrinologist, sir. As such, in dermatology, no much is there. So little absorbents we prescribe, that is not the final answer. We have to find out the exact cause. Then only treatment will be easy.
And alopecia areata, sir?
See, alopecia areata, what is the reason? There is a local autoimmunity. Local autoimmunity for hair follicle, the roots of the hair follicle. So that's why reasonably 1 centimeter, 2 centimeter, sometimes 4 to 5 centimeter, the hair fall will be there. So at that time, there is a topical drugs are there. Best topical drugs, what I have found out is minoxidil. Minoxidil, it is called topical solution. Roll on, just like this Vicks Eparub and Iodex, we get roll on, like that type minoxidil comes as a roll on. So we should apply this particular drug 3 to 4 times a day, and we give little good hair tonics which contains biotin, and over course of 2 to 3 months the hair starts coming out well. Otherwise we have to give intralesional triamcinolone injection, sir.
Thank you so much, sir.
So any questions, sir, from the audience?
How to treat
There is a one
complicated
question from
skin
Dr. Harani.
infections.
Dr. Harani has asked sunburn. Madam, only two things. Sunburn. It is because of scorching ultraviolet rays. We have to give topical sunscreens. The best sunscreens is natural umbrella. Then any particular just simple powders, they also act like a sunscreens only. Then ready-made available sunscreens like photoban, sunban can be prescribed, madam. They take lot of time to resolve.
Sir, can we see this alopecia areata among the students or students with the stress?
Yes, sir. The stress is such a wonderful, what we call the psychosomatic. The disturbance is there in the mind. It manifests somewhere in the body problems. So especially exam going students,
Yes,
they
especially
develop.
NEET exam going students. I saw
Yes, sir.
a medical student, medical graduate appearing from NEET PG with alopecia areata gone somewhere. Then on sertraline, 50 to 100 milligrams, she recovered very well.
So that's why I told this alopecia areata, all this hyperhidrosis, they require the treatment with the help of our psychologist friends.
Surprisingly, everything went well. She recovered so well.
Yes, sir. Probably anxiety has come down. Probably our parents wanted MBBS or whatever seat. She must have got. Anxiety come down and automatically there is a normalcy of hair, sir.
Thank you, sir. Good presentation.
Sir, there is a question.
Yes,
Can
sir.
we prescribe multivitamins for viral infections?
Sir, multivitamins overall, they improve our body strength. So as such, they will not have a deleterious effect on the viral infection. The present day antiviral drugs are extremely good, sir. Acyclovir, valacyclovir, famciclovir, and especially the acyclovir and valacyclovir, regularly I am using. Side effects are absolutely zero side effects. We can use the drugs confidently, sir. But these are all the add-on drugs, B complex, multivitamins, multiminerals.
And there is another question by Dr. Nagaraj, sir. Complicated scabies infection treatment.
Yes, sir. There are two things are there. One, we have to treat bacteria which has produced the complication. Then we have to treat the ectoparasite Acarus cabi. Acarus cabi can be easily managed by simple ivermectin tablet. Then secondary bacterial infection has to be treated by one of the good antibiotic, either augmentin or taxim drugs, taxim like drugs. If only one particular complication where there is a acute glomerulonephritis secondary to streptococcal infection, that time we have to take the help of, depending upon the age of the child, either pediatrician friends or physician friends. Then only we can help the patient. The ivermectin, wonderful drug, it will immediately kill the ectoparasite Acarus cabi. The antibacterial augmentin will take care of all bacterial infections, sir.
Sir, another question from Dr. Subramania.
Yes, sir.
What is the treatment for androgenic alopecia, sir?
So, yes, sir. Androgenic alopecia. See, probably you must have seen my head and told, sir. Androgenic alopecia is a hormone related. And nowadays, the best treatment is by our cosmetologist friends. They do hair transplantation. That is a wonderful and it is extremely good, but it takes little procedure. Hair transplantation is the best, sir. Our drugs, they may take 1 year, 2 year, 3 year to show good results. Minoxidil topical, we advise, sir.
Okay, sir.
Fenestride also we advise, but results are not excellent.
Sir, how about TNI treatment, ketoconazole, fluconazole, you told.
Yes, sir.
Any contraindications, sir? For long treatment.
Contraindications, sir, usually when patient is on multiple drugs, for example, he is also having diabetes, he is also having a kidney problem, he is also having a heart problem. Nowadays, in most of the major institute, we see such patients. When these patients are there, they may not tolerate our antifungal drugs. We have to be little careful. So at that time, instead of giving full dose, we can give little half dose. But topically, we can give antifungal drugs topically twice a day for minimum 4 to 6 weeks. Itraconazole and terbinafine both will have an interaction with the other drugs used for kidney problems and cardiac problems, sir.
So any other questions? Can anybody ask? Sir, calculator, sir, can we close?
Yes, if no questions, close it.
Hello, sir.
Tell
Hello.
me.
Yes,
Sir,
sir.
Namaste, sir.
Yes, ma'am.
Hyperpigmented skin because of this hormone. Some dermatologist prescribe steroids, sir. Is it helpful?
100% it is helpful, madam. The reason is the steroids overall they suppress the immunity. So when they suppress the immunity means they also suppress the melanocyte overfunction. So automatically there will be less melanin deposition and automatically there will be a hypopigmentation. Slowly it will take almost 1 month to 3 months.
At the age of 55, 60, we can take the steroids, sir?
At the age of 55 to 60 means almost it is a cloasma. Cloasma, or it is also called melasma, mainly on the forehead and on the cheeks. So along with the sunscreens, mild steroids can be given, madam.
Okay, sir. Thank you, sir.
Sir, President, sir, can we close, sir?
Arvind, sir.
Hello.
Hello, sir.
Sir, we can close now. No questions.
Sir. So I thank Dr. Hanmantaya, sir, for a beautiful presentation, and the whole the dermatology is covered. I think virus, fungus, warts, varicella zoster, herpes simplex. So I thank Dr. Hanmantaya, sir, for the wonderful presentation with pictures, and it will be useful for the practitioners, general practitioners, or any other practitioners also. So I thank you, sir, for the wonderful presentation, and I thank Dr. Veerbhadra, sir, President, IMA KSB, and Dr. Suri Raju, sir, Secretary, IMA KSB, and the President-elect, Dr. Harish Dilanabettu, and other members of the IMA, office bearers, and the audience for attending this Zoom webinar on the topic common skin problems. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you, Mahesh.
Thank you, sir.